ready to get going again. There are a few people still moving around back there, but I'm sure they'll join us soon. So about to launch into the afternoon. So a couple things to keep in mind. So folks who took notes at the tables, please keep those notes, because after this panel we're going to spend a little bit of time just having a broader discussion about what we've learned from the day, and we'd like to use the notes from your table discussions as kind of a springboard into that conversation. So we're going to be asking you to come up and maybe do just a little bit of a report out about what you discussed, maybe some of the issues that came up, things that you didn't think were covered that maybe we should talk about in this venue. So be thinking about that. We gave you a whole hour to kind of get your mind together on that. With that, I'd like to kick us off into the next panel. And I'm going to introduce Wendy Rogers, another of the co-organizers of this symposium. So Wendy is the Shahid and Ann Carlson Kahn Professor of Applied Health Sciences in the Department of Kinesiology and Community Health at the University of Illinois, Urbana-Champaign. Wendy, please.
I've been told not to touch the microphone. Keep my hands to myself. So I'm going to just spend a few minutes, 10 or 15 minutes, reorienting us a little bit to the afternoon focus. Thank you, Vince. And trying to think about some of the systems level issues, and a lot of the things that we've talked about already this morning, I think we will be addressing this afternoon, so I'm very excited about that. So a systems perspective on aging in place, we've heard that term used a bit today. There's a few key points that I'm going to list out first that I want us to keep in mind as we're going throughout the panel this afternoon. Coordination and integration, I think, are key terms for us to keep in mind. Care as a continuum that often occurs outside of acute care in terms of management of chronic conditions, comorbidities, transitions between hospital, rehab, and home. Some of these issues have come up already. We need to make sure we have good communication, data flow, information visualization, integrated care plans, and a systems approach. And believe it or not, I made this slide up before I heard everybody's talks this morning, but a lot of these issues have already come up. So let's start by talking about aging in place. So this term is used a lot, and personally I'd like to change the way we think about aging in place. This is the traditional term, so remaining in the same residence where one has spent his or her earlier years. And I hear a lot of people saying, well, that's what everybody wants. That is not really necessarily what everybody wants, but that's what we think about as aging in place. So some broader definitions. One is each resident's choice, I think that's a key word, to remain in his or her living environment, otherwise known as home, regardless of their physical or mental changes that may occur as he or she ages. So it's a little bit broader, but I like the CDC definition. The ability to live in one's home and community, that's the key, and community, safely, independently, and comfortably, regardless of age, income, or ability level. So I'd like to think about aging in their place, like where they happen to be. They are aging there, and we should be thinking about how best to support that. So where do they live? Many people, these statistics are for people living independently, not in communities. And you see that if we look at the men on the bottom, 70% of men are likely to be living with a spouse or a partner. Some are living alone, some have other arrangements. When you look at the women, though, there is a much larger percentage who are likely to be living alone, so we need to be aware of that. We also should be thinking a little bit more broadly about living environments. I don't think I've heard this term yet today, but there's something called a NORC, which is a naturally occurring retirement community. And these are neighborhoods or buildings, apartment buildings, where a large percentage of the residents happen to be older adults, and they are all aging together. And that terminology comes from a contrast of planned retirement communities. So these are naturally occurring retirement communities. There are also continuing care retirement communities, which have different levels of support: independent living, assisted living, and skilled nursing, where varying levels of support for activities of daily living or instrumental activities of daily living are provided. We were just talking at lunch that this term is not going to be used anymore, so now the new term, you have to keep up with all of these things, the new term is life plan communities, which is a more positive way, going back to our talk this morning about being more positive, about thinking about this as a planful way to enable you to live well. So let's talk about technology for aging in place. I'm going to highlight a couple of components of this definition. One is to thinking about technology that can alleviate or prevent functional or cognitive impairment. Another component is to think about how we might limit the impact of chronic disease. We may not necessarily remove it, but we might limit the impact. And then third is enabling social or physical activity. So these are various aspects that we might think about when designing technology for aging in place. And we've already had some discussion this morning about the different types of technologies. There may be wearables, there may be telehealth systems, robotic systems, technologies that are integrated with scooters and wheelchairs, for instance. So we need to be thinking broadly about technologies. So Jennifer mentioned this morning this report. This is the one that she was on the panel of. It's called Healthcare Comes Home, The Human Factors. And the PDF is freely available. It was put out by the National Research Council. I encourage you to look at it. It has a lot of very useful information. And one of the things that is in this particular report is this model that is meant to give us a context for how to think about healthcare at home. So you see in the center we have the people and their cognitive, perceptual, and physical capabilities. We have, I'm going to see if this, it's kind of hard to do the angle, but you just follow with me. Then we have the demands that are imposed on what it is they're trying to do, cognitive, sensory, and physical demands. We have equipment that they're working with, or technology, and we have the tasks that they're trying to perform. And then we have up at the top the different environments. What's the health policy environment? What's the community? What's the social? What's the physical environment? So this model lists out a lot of things that we should consider on the person side, a lot of details we should think about on the technology side, and the details for the tasks that they're trying to perform. So this looks like a very comprehensive model, and in fact it is, but even this is not complete enough to capture all the issues that we need to think about. So my colleagues and I tried to use this model to understand the challenges that home healthcare providers are facing. And these are professionals, so we talked a little bit about the professionals. We interviewed nurses and certified nursing assistants who go to the homes of older adults to understand what the challenges are that they are facing. And so we tried to use that model as guidance, and what we found was it didn't have enough detail about certain things. So first of all, instead of just talking about the person, you need to talk differently about the care recipient and the care providers. What are their specific needs and goals and capabilities? Another thing that came up in our research was the role of affect. We've talked about that this morning. That's not captured in that model at all. And it's the affect of both the care recipient and the care provider. Affect can affect your capabilities if you're feeling good and doing well, but it can also impose demands if you're not doing well. Also lacking, which we discussed this morning, training. This is a very important issue that came up in the context of our healthcare providers saying they didn't have the training that they needed to do what they were being asked to do. And then the physical characteristics, somebody asked a question about that, and we need to make sure we're paying attention to that in terms of more physical limitations or impairments, for example. The other things that we relabeled it, instead of just thinking about technology, to think about the artifacts that home healthcare providers have to deal with in that context. And instructional support for them, setting it up, troubleshooting when something goes wrong. They're going into people's homes and having to use those people's technologies or their devices, and if they don't work, it's very difficult for them to provide assistance. And a lot of people, those folks who work in care, know that they often are using devices that are been around for a very long time. They've been degraded in their quality. Another aspect is the importance of adherence to standards. Why is one glucose meter so different than another, and not being able to use them interchangeably? So even though the model from the National Research Council covered a lot, there's still things that we found need to be paid attention to. I want to give another example from the area of human-robot interaction. So I do research in this area, and if you're designing robots to support older adults, again, what are the things you need to think about? You need to think about the human characteristics. What are their capabilities? What are their experiences? What are their personal goals? You also you need to think about the characteristics of the robot. What does it look like? How does it work? Does it display emotion? Is it adaptable? How transparent is it? Do you know what it's going to do next? Is it predictable? You also need to be aware of the tasks that are being performed. Is the robot and the human working together? Is the robot doing one thing and the human is doing something else? Do they have to be in close proximity? All of these things are important considerations. And then, of course, the context in which it's being used, the physical environment, the social environment, and the use context. So just another example of some of the complexity that we need to think about in this context. The last example I want to give is about the integration of information. And I have integration of data and information. We get a lot of data from wearables and sensors and other things in the home, for example. How do we integrate that and share it across contexts? So this next image is something that Beth Minot and the Georgia Tech folks worked on. We were trying to think about the blue space is the home environment, where you have different sensors and maybe a medication tracker, an on-body activity tracker. You have sensors in the environment. All of that information has to go somewhere through some hub, we called it a gateway, to then link to how can you turn that data into information, right? Well, how do you transform it to be useful? Where do you store it? How do you protect it? We've talked about privacy, security issues. And then how do you link it with electronic health records and all of these different systems? So this shows the complexity of trying to get data into information into being useful. So the theme of my remarks here are to embrace the complexity of the problem. I think that we collectively oversimplify things. We think it's going to be relatively easy to do something. It's not, right? And I think rather than try to simplify things, recognize these are complex systems. Recognize there's lots of different parts that need to work together. We need to think about the person and the task and the technology. And it's only if we do that are we ultimately going to be successful, not only in the design, but also in the implementation and the actual deployment. So that's just setting the context for our discussion this afternoon. I'm excited to have 3 different panelists who are going to come up, and I'll introduce them in turn, but they represent different aspects of some of these systems issues. So I think we'll have a lot of discussion around some of the topics that came up this morning and hopefully spark some additional ideas for discussion at the end of the panel. So with that, I am going to invite Majd Alwan to come up. Get my cheat sheet over here and I'll get out of the way. So Majd is the Senior Vice President of Technology and the Executive Director of the Leading Age Center for Aging Services Technologies. He'll tell you a little bit more about what CAST is and then give us his perspective.
Thank you, Wendy. Good afternoon, everyone. So, how many of you have heard of Leading Age? So few. For those of you who are not familiar of Leading Age is a 501c3 organization that has under its umbrella over 6,000 aging service provider organizations that include life plan communities, that include home health agencies, assisted living, skilled nursing facilities, naturally occurring retirement communities, housing with services, home care, home health, you name it. The only common factor across all of these organizations is that they're all not-for-profit. And our members, we have state partners and affiliates in 39 states, and our members collectively serve over 4 million older adults and caregivers on a daily basis. So you've heard from Amy from the CJE, which is a leading age member. You've heard about Self-Help and their senior center, virtual senior center. They're a leading age member and cast member. We've heard about Easter Seal from Mr. Swirno. They are also a leading age member. And CAST is a unique program within Leading Age that brings, in addition to these forward-thinking providers, together with technology developers, both from universities as well as from technology companies, large multinational technology companies like Philips and Hewlett-Packard, as well as smaller startup innovative companies. Around the premise of technology, and we try to raise awareness to available technology solutions, identify barriers, and advocate for the removal of those barriers. Back in 2010, with the passage of the HITECH Act, you're all familiar with the HITECH Act, which provided funding for electronic health records. There was a provision that mandated the conduct of a national study to evaluate and look at aging services technologies and their promise. I've had the honor and the pleasure of being the co-director and the co-editor and co-author on several of those chapters. So this study was conducted by the Department of Health and Human Services, the Office of the Assistant Secretary for Planning and Evaluation. And rather than looking at technology in general, we sort of took a step back and decided to look at the most common issues, care issues that are common across older adults, that are prevalent among older adults, as well as have some impact on the disabled individuals as well. So those who have disabilities. And we decided to focus on those 8 issues that are most prevalent and most costly, not only in terms of financial cost, but also in terms of societal burden and burdens on family caregivers as well as the caregiving system. So again, those are the 8 care issues. Falls are prevalent. 33% of older adults experience at least a fall. And the cost in 2012 was about $19 billion a year. Chronic conditions, we focused only on the five big ones: the heart failure, diabetes, hypertension, asthma, and congestive and COPD. And these 80% of the population 65 and older have at least one of those conditions, and the cost is over $484 billion a year, plus over $279 billion of informal care that the family members carry the burden of in terms of caregiving. Medication mismanagement. There are annually over 400,000 adverse drug events. Only if you look at just non-adherence, less than 50% of the adult population in the US actually take their medications as prescribed. If you look at the older adults, it's actually more than 2/3 of older adults take their medication prescriptions as prescribed. And that alone costs the society about $177 billion a year. Cognitive impairments, again, the percentage is much less, it's 16, but it's also close to $200 billion a year. Sensory impairments, including vision and hearing loss. Depression, as we've heard about, which is rooted in social isolation as a risk factor, and has the impact of smoking 15 cigarettes a day, or close to a 1 pack a day, costs about $83 billion a year. Immobility, functional decline, which is one of the biggest one and the main cause for needing long-term care, either transitioning to an assisted living or transitioning to a skilled nursing facility. That alone costs about $236 billion in terms of ADL, IADL support. And for the family, it costs, according to the latest estimate by AARP and some other agencies that collaborated with them, more than $500 million a year based on the 2014 estimate. So those 8 conditions cost us well over $1 trillion annually. And if you look at so we looked at these, we looked at the technology solutions that are available, the efficacy evidence and cost effectiveness evidence, and there's a ton of evidence of efficacy. But guess what's the most effective strategy for prevention of most of these conditions? Physical exercise, physical activity, Tai Chi, and so on and so forth. So again, technology could not reach anywhere near that kind of evidence. And we know that an ounce of cure is worth more than a pound so an ounce of prevention is worth more than a pound of cure. So we need to focus, in my opinion, on prevention. And if we are the most effective way we can impact society in terms of aging, again, especially if we're thinking about creating a research center now that will impact society in the next 10, 15, 20 years. I'm 53 today. I want the outcome of that research to impact my life. So we probably should be focusing more on prevention and more on healthy behavior, encouraging physical activities and exercise, encouraging healthy diets, encouraging self-management. But we know that self-management is not sufficient. So self-management is significantly improved when there is clinician engagement, because that provides a trusted source and reinforcement. But again, if we're thinking about clinician engagement, we need to think about how are we compensating for the time of that clinician engagement. So again, we need to engage the payers. We've heard about social engagement and not only with family and friends and peers, but also with the broader network of caregivers, including the frontline CNAs and home care workers that are in close touch with those individuals and are the most likely to notice any change of condition, which could be a precursor or a trigger for preventive interventions. So as I said, the report, for those of you who have sleep problems, it's over 200 pages, no pictures, nothing. So I advise you to read it right before going to bed. But there's a ton of technologies and there is a ton of evidence of efficacy. But still, we don't see broad adoption of these technologies. Why? A number of reasons. Number one, there is lack of awareness generally. People don't know where to look for these technologies, especially among the trusted referral channels. I'm referring to physicians, nurses, physical therapists, OTs, and so on and so forth. So that's number one. Number two, variability of evidence of value, right? Most of the studies that we come across, they're single studies, mostly smaller pilots, mostly run for some of them are not controlled clinical trials, and most of them are over a short period of time, and the vast majority are not done under the right payment system, are done under pervasive or payment models that do not provide the right incentives. So there's a huge gap. And again, the biggest absence of business models is the biggest gap. So let me give you an example. We're all familiar with telehealth and remote patient monitoring, biometric remote patient monitoring specifically. And we know that it's very effective in managing congestive heart failure is the poster child. Hypertension is another. Diabetes is a third. And we have, again, strong evidence of efficacy, but very limited evidence of cost effectiveness because, again, mostly they're done under the pay for service type models. The only exception are systems like the Geisinger health system, like the Kaiser, and like the Veterans Affairs. Those are integrated systems where the payer is the same as the provider. So when they implement these interventions and see benefits clinically as well as cost reductions, it encourages them to adopt these technologies at a broader scale. So again, I think that's why we at Leading Age are calling for demonstration projects from CMS and CMMI to not only demonstrate the cost effectiveness, but to change the payment models to reflect the innovative or be more adaptable or more suited for the new kinds of innovative care delivery models that we're starting to see. So as areas of research, I would highly recommend focusing on physical exercise, lifestyle, self-management. I talked about all of these things, but keep in mind that we need to keep the applications need to be fun and sticky and sort of focus on what gets a person ticking, so to speak. So remember the example of the dementia individual, the architect, right? We need to implement behavioral science and behavioral economics principles. We need to ensure that we have a user-centered design from the get-go, from the conceptual level, and we need to think about the business model. And frankly, we cannot think about the business models without engaging the payers. And the payers, we're here in Baltimore. Anyone here from CMS? And CMS has a headquarter right here. Anyone from CMS?
I used to work for it.
Right. So again, I'm trying to demonstrate that we need to engage CMS, especially the Center for Medicare and Medicaid Innovations. So again, my recommendations is to have an audacious goal to develop technologies that would reduce the prevalence of these, would do the exact same thing that physical activity and exercise and healthy lifestyle has. And reduce the prevalence of chronic conditions, because we know it is the root of all disablement, both cognitive as well as physical. Focus on younger, older adults. I would like to see myself being potentially one of the recruits and the clients in the research, as a research subject. Start with want-driven solutions. We're seeing the evolution of voice first, and how people are sort of adopting these technologies at much higher rates than anticipated. But we need to make sure that the applications the technologies are flexible and allow layering needs-based technologies, including sensors and devices and applications down the road. And of course, we need to make sure that these solutions are scalable and affordable. Leveraging pervasive mobile personal devices and the Internet of Things, which almost everyone has in their hands these days. So lastly, I would recommend focusing on interoperability and developing technology that interconnect and interoperate and integrate with existing broadly adopted technologies, such as mobile devices, such as health IT, which the country has invested close to $40 billion in recently, and make it work to our advantage, and facilitate data exchange so that we can give providers more comprehensive, not only data, but information. So we need to focus also on analytics and presenting information as opposed to just overwhelming data. And we need to work on facilitating care coordination and delivery across provider setting. So thank you so much.
Thank you, Maj. Next up is my colleague from the University of Illinois, Kesh Kesavadas. He's the director of the Healthcare Engineering Systems Center and professor of Industrial and Enterprise Systems Engineering at the University of Illinois, Urbana-Champaign.
Thank you, Wendy. So I'm going to focus on community. So in the morning, we said that community is very important. So I come from the engineering background. I'm the director of the Healthcare Engineering Systems Center, as Wendy mentioned. And as some of you know, that Wendy moved to Illinois like 2 years back. And this collaboration has been great, because now we are able to think of how engineering can help the area of aging and the technology. So my center focuses on looking at technologies like simulation, IoT sensors, data, and try to find solutions for that. And also a very unique element of our center is that we work very closely with one of the largest rural hospital systems in Illinois called Order of St. Francis, also known as OSF Hospital. And we have been very fortunate to have an endowment through this OSF Hospital, about 50 million, which is the largest endowment that we have at U of I. So this gives us an opportunity for us to build systems that has real application in a health domain. So I'm going to focus on two things today, and one is see how the challenges in the rural community can be met by technology, and number two, how we can build communication systems and things like that, which can bring the community closer and make it more practical to apply them. So the challenges in the rural community all over Midwest is huge. When we talk here about independent living and people living inside the homes and things like that, this is something that our hospital systems in rural Illinois and other rural parts of the US see every day. Like in Illinois alone, there are about 1.5 million people who live in rural areas. When you think of Illinois, you think of Chicago. But in fact, almost a half of the population live outside Chicago. And they live in very small communities. Illinois is a very large state. If you go from the tip of the lake till the southern tip of Illinois, it will take you 6.5 hours to drive. So it's a very large and long state. Almost 92% of this area is rural, right? That gives us a lot of challenges because many people in the rural area have to drive 60 to 100 miles to reach a nearby community or a community hospital, right? So that's a big challenge. So providing this independent living for people in the circumstances is indeed very difficult. Even assisted living facilities are very few for these communities. I can go on and on. Who are the people who actually have problem because of that? It is the elderly population who have chronic conditions which needs them to go to hospitals. And by the way, there is an overlap between young people who have chronic conditions and elderly population as well. And people who have problems and they had a surgery, like for example, a cardiac procedure, they go back home and this causes a lot of problems for them when they live in very rural community. So I'm borrowing from some of the data analytic work that is going on through our hospital system. And there are 4 areas that have been identified as major problems for rural community. Number 1, believe it or not, is transportation. Transportation is a very big problem. A third of the people never make it to the hospital appointments because they could not find a ride to reach a hospital, right? And that's a huge problem. People have problem going to grocery stores, right? Many communities don't even have a good grocery store nearby. Issues related to cognitive and mental health is a very big problem as well. And more recently, as you know, there's also things like opioid and things like that. Food security is another very big problem. So I'm sure all of us have read the study that you can look at the health by looking at the zip code of where you live. And the zip code also tells you the kind of food which you can find. And most often, it is a small grocery store attached to a gas station in some of these communities. It's a very big problem. And the fourth problem is companionship. There's almost 1 million families in Illinois where there's only one person living in the house. This is a mind-boggling statistic. So people living alone is a very big problem. So this is just a quick capture on the people who we work with. OSF Hospital and our center have this collaboration. So I'm going to talk about, it's mostly about that. So if you want to give good health to elderly population, then some of the issues have to be met, like aging in place, but doing more for people who have less. These are some of the things that OSF is looking for. And access to care. Both at University of Illinois and Chicago has a very big program looking to access for care. And that is what we talk about when people have to drive 50 miles to go to a hospital. But access to care is also a problem in certain parts of urban Chicago, where people have problem accessing and going to the nearby hospitals. So if you want to improve the lives of people in rural community and aging population, then we have to think of this as a connectivity issue. How can we connect these people with the people who can help them? And the people who can help them are not just the family, but it's also the community, the nearby churches, nearby community health centers, and so on and so forth. So we have been trying to identify these things, right? What are the issues? One are who are the people? Which are the families in this community who need help? If you know that, how do we monitor the help at home? Can we monitor them at home? How can we identify people who need help? Like talk about triaging. Certain people needs to be moved to hospital. How do we get the community involved or community told that there are people living in your community who needs help? And then how do we let the right people know that you need to go and meet these people? So this is the big issue, and this is a very big complex problem because it starts from identifying and keeps on building. And as we study this problem more and more, we realize that this problem is not very simple, right? Data analytics is the big part. That is what we are doing right now, is analyzing data, looking through all kinds of data, both from the US government and also hospital system. OSF has a 3 million people database. So we are scanning it. We are trying to find out how we can go deep into this database, trying to see what kind of monitoring can we do and so on and so forth. So we have been looking at what we call a 3-tiered network. We have, in fact, a proposal that we wrote at National Science Foundation. In fact, Johns Hopkins was also one of the co-PIs, co-investigators from Scott from the center here, Malone Center. And so we thought that if you want to really connect the people, we have to think of this as 3-part network. So one network is people like family, friends. They're what we call the social network, right? So we have to find out, are there people to reach out to when people need help? And the others are people who live in the community but may not be a family or friend. The second is something very unique, which OSF has been experimenting, called Community Post, and I'll talk more about that. And at the top is the hospital system. So idea is that we want to keep away from people from the hospital unless they really need to go, and keep away people from very, very expensive kinds of engagements if we can actually keep people at home. So we see that if we can do a network between these organizations and have a way so that the information is spread, then perhaps you can build a better connected community. So the idea of Outpost is something that's being experimented for last 2 years. There are 3 of this Outpost built. So Outpost have very specific roles of people who work at this Outpost. So the basic funding for the house comes from the hospital, but the hospital has managed to go and meet people in the community and got them engaged to work with Outpost. So not everyone is an employee. Some people are volunteers. So they have different roles, like a champion who's sort of the leader who runs the community outpost, process experts, these are people who understand the health delivery system, community liaison, these are people who can work with the nearby churches and community organizations, and clinical team, these are the team, occasionally they would come to check blood pressure and things like that. So this outpost concept is somewhat unique in the sense that they are really not a typical hospital community center, but these are centers created in a really, really rural area which has a problem because the closest hospital is 80 or 70 miles away. And then the next challenge is, if we do monitor people, how do we get information from people and spread it around? So we are looking at this as a network problem, as a communication problem. So the communication problem is, if someone at a home needs a help, how do we identify that? And how do we know, is this need something that requires a 911 call? Or is it something that someone has not actually got up from the bed whole day? For example, is there someone looking, why did this person never actually got up from the bed? Is this person sick? Because, well, that's one of the reasons. Maybe this person has not gone to grocery for 2 days and does not have any food to eat in the refrigerator. So there are different levels of needs, right? At the same time, if it's a chronic condition, people, maybe they need to be checked, like the blood pressure and so on and so forth. So it's a very complicated problem. So we just tried to build this network. So we had some people look at all of the different kind of communication. We saw that this is actually a very complicated network. So one of our effort is to try to see if we can actually build and prototype a software system around this community outpost where we will give people a telephone with some kind of a communication protocol, and then try to see if we can do something what we broadly call triaging, and that is based on the data and using some kind of a analytic AI engine, try to see whether we can categorize these kinds of monitoring to whether it needs a clinical help, or is it simply that sending a text to someone who's a family or friend is good enough to someone to call, come to their home and check. Maybe it's a community, someone who lives in the community walks and knocks on the door and find out is everything okay. Maybe perhaps even that can help people feel more confident that they can stay alone at home. So we are trying to see how we can combine information perhaps in the hospital database at the same time with the data that we can collect from home to do what we call the triaging for this network. We have also looked at broadly, we discussed about technologies, this whole session is about technologies. We have spent a lot of time trying to think what are the technologies that can really help these kind of situations. So we think of people who are young, just getting old, like the previous speaker said, I'm 53, I'm same age as well, and if in that you're still healthy but you have some chronic problems, then there are people who need some assistance. And finally there are people who really need, who at home needs a lot of assistance. It's almost like creating an ICU at the home. Can we do that? Can we stop people from coming? So there are all these horizontal technologies which could be a foundation of this. And a part of that is also testing these technologies, looking at how we can bring hospital and the society to the network, and looking at other technologies we did not talk about, like point of care sensors, which can track people. For instance, if you have a fever, infection, sepsis, can we track them at home rather than finding it out 2 days late by the time the person is almost in the deathbed, which happens a lot in the rural hospital. You probably know that the chances of dying out of infection is 50% higher if you live in a rural America as opposed to living in a city. It's because people don't diagnose things like infection and sepsis much as well as they do in big hospitals. And looking at, can we analyze data to identify people who need help? You will see one of the posters is my colleague R.S. Srinivas is sitting in the back. He's working on a project trying to use a voice-activated system to help people. So one of our ideas is something that has been prototyped by OSF. Interestingly, a very innovative concept. About 200 patients who went home after cardiac surgery were given a set of sensors connected through the Intel CarePoint technology, and they were monitored 24 hours. Their blood pressure and things are being monitored. About 200 people, and what they noticed is that the call to their 911 for these people were 35% less than people who went home without the sensors, which just shows that just being monitored, the concept that you're being monitored put people's mind at ease and they don't call 911, right? So this study and the graph that's been generated for the last 2 years is really amazing, that the fact that people feel that they're being watched or someone is looking after them itself creates a lot of less stress for people who are in a situation like a cardiac issue. So the question is, if we can monitor them, can we make their life easier through voice-activated system? Like for example, if you're required to do an ECG measurement, say once a day, if there's no one to do it, maybe something like Alexa, tell me how to put the lead can help you. And a very clever idea that RS and a couple of the students came is, you have a little bit of a dementia issue. You don't remember. Alexa can help you. What am I supposed to do today? Well, you're supposed to take ECG. Where is my sensors? Oh, you left it in the left drawer in your kitchen. Well, those kind of conversation automatically being recorded by Alexa. So we have this term called concierge, can be a concierge inside the home to help you with day-to-day activities, and perhaps also reach out to the hospital if there is a need for that. Just all the IoT sensors today that is available is actually practical. The question is who will cover and who will pay for these kind of issues. So in the end of the day, this kind of monitoring is going to help the hospital system, but it's also going to help the community by giving help to rural population to live independently. And I think that a lot more work needs to be done in this area, communications, software. I think these are the challenges that even the federal government should take part in, because in the end of the day, this is going to cut down some of the big costs involved, like the last speaker said, in non-compliance and things like that. Thank you.
Thank you, Kesh. Our third panelist is Ayse Gurses, who's an associate professor and the director of the Center for Healthcare Human Factors at the Johns Hopkins Armstrong Institute for Patient Safety and Quality. Take your time.
Hello, good afternoon. So I want to talk about some of the work I have been doing in this domain. But before that, before diving into the details, I will probably make three big points that that are the underlying themes. And I like how Wendy framed that this is a complex problem. Just because it is home doesn't mean it is much less complex. So with that concept, this is really a systems issue. So when we say we are engineering home or engineering future home or care at home, we are actually engineering the entire work system and system of systems. We shouldn't think about what is the technology next, what technology, what secret technology or whatever magic technology will solve the problems. We need to think about how we can design the entire work system, including a technology, to improve the outcomes and processes for older adults. The second point related to that is there is a patient family work system or home work system. But that work system is also not independent of many other work systems. How the hospital is helping you in terms of your discharge planning, how the home care work system is working, how the community pharmacy work system is working, all of these are interacting and affecting that patient family home system. So one big idea about that is designing always for situational awareness and shared mental model across these work systems. If we can achieve that, which is a big problem, I would also encourage with the third point being, in the meantime, if we can achieve, there is no right, yes achieved, no achieved. It is a matter of probably how close we get. We need to also think about, as engineers and methodologists, what processes and methods have worked for useful innovation design, work system redesign, because we need to keep improving the methods as human factors methods who will be able to deal with, for example, these complex work systems and the different work environment. We need to improve how we work with different types of engineers, different type of stakeholders. And if we get some key lessons from those, actually they will be much more valuable than the specific product or outcome we will achieve. With that, this is like some of the main points, but I want to go over some of the work I have been doing recently. So I work a lot in the care transitions domain from hospital to home. As you know, this is a risky period, common, costly, and older adults are particularly vulnerable, and going home is risky. This is a recent paper we published just describing, modeling the complexity of care in transitions from hospital to home with home care, different people involved. You can see all these color, like pre-hospital discharge, the processes, admission to home, and post-hospital discharge. So as you can see, there are many interfaces of work systems. And what happens is when you hop on and go with the home care nurse, I did go with some of them. You can see this is their office. They work from their car basically with a laptop. What happens is they are still figuring out what is the last medication prescribed, what is the last lab value before discharge, is this the last discharge documentation given to them. So they always struggle with that. In the middle you see a picture from Baltimore area, an Italian family, and I have today in the morning Dr. Taylor was asking about this handover tool, whether we can design tools to support handover between caregivers. The one on the right is actually a handover tool that was developed by this family. The father, who is very sick, this is like an intermediate. In the middle, you can see the medications. There's a patient bed, some other devices, and the father is pretty sick, and there is a mother, two daughters, and one son. The son turns out, the two daughters and the mother taking care of this father, and they decided that they need a handover tool, a file actually, just like a medical chart in the home. The son developed this chart in the Excel with different color codes, etc. You can see pages. It is pretty sophisticated, but they designed it based on how they do the work at home. So artifacts like this is great for understanding the needs of people in the home and how they organize or reorganize their work. So some of this, my work is driven by this SIPS model, Systems Engineering Initiative for Patient Safety, which we have version 2 of it, which explicitly talks about patient-family work and collaborative professional patient-family work. And all that work, as you can see, is affected by how we design the larger work system. Tools and technology being one of them, but the tasks, the physical environment and the organization, the culture, the community, all of these are affecting the care or the patient work being done at home. Now I will talk about a particular study. This is a study funded by HRQ. I serve as the PI along with Yan Jia from University of Texas Arlington, and also Dr. Abibi is here also on the study team. The post-discharge adverse events is a serious problem. We know that, and especially this is true for older adults with multiple complex medications. So this is the approach, the way we are thinking. There is a patient family in the middle. They are admitted and being discharged. All of a sudden, they are pretty passive in the hospital. Their medications are brought to them. Everything is like, they don't need to think about what is the next care activity. And then, boom, all of a sudden you are in the home. And you need to take care of yourself or your loved one. And that transition period, the discharge education, as we know, is more than ideal currently. You know, I have been also in hospitals that when I ask, what is this medication for, nurses telling me I have no idea. So these types of situations are more common. So how can we develop partnership opportunities for, in this case, this is a medication safety project, medication safety, looking at community resources, community pharmacies, primary care, ambulatory and home health care, with patient and family being in the center of all of that. What we are doing in this particular study is we looked at patients' work systems. Basically, we went to people's home and tried to understand what is in their home that may predict, that we can use to predict which of these patients perhaps will get into trouble in terms of medications in the future. So that is the risk assessment tool that we are developing. So we looked at all the sites. We looked at the inpatient team because again this is system of systems, not individual isolated system. We looked at the inpatient team in terms of how they prepare the patient for medication management at home. We looked at, we talked with the home care and transitional care team, and then we also talked with patients. But now this is like a more longitudinal approach. We did patient home visits multiple times. First visit was like 24, 72 hours after discharge. Second was post-discharge, 2-4 weeks, and a 3-month post-discharge call. Based on all of this, we tried to understand what is in the patient work system, family support, the changes in medications, whether they, what community resources they have, many different factors that may have an impact on medication problems in the future. And then we have developed a tool that we are now using to assess the risk and basically use it as a clinical decision support tool in the future if this gets validated, to figure out which of these patient clusters need what kind of resource and support. Because currently the way people make those decisions is mostly based on patient's acuity, which are important things, but they are not systematically thinking about the risks in the patient homework system, trying to predict them and bringing them upstream before they get discharged so that they can figure out how to make that patient family work system safer when they go home. This is being now evaluated with 440 patients in 2 hospitals, 2 pharmacy techs are collecting data on this full time. So some of the findings very quickly. Discharge education needs a lot of, we can definitely innovate on that. There is a lot of role ambiguity. We talked about that. Patient and family, which family member will do what, because they don't even think about these things before they go home, and boom, all of a sudden you are at home and you need to do these types of things. And a lot of poor design of patient materials. This is like the same patient, same hospital, different formats in medication information. So you can see, I mean, consistency in design is one of the main principles of engineering, and you can see how these things, even for same patient, differ. Arriving home is also, as I explained, because of time I will skip, is pretty chaotic. There are many different ways people deal with that. On the picture left that Dr. Abibi is working on, you can see how the same information needs to be presented or made presented in 4 different ways, and how patients still, family caregivers still don't use the format given by the hospital, but they reformatting it to fit to their mental model and their workload. So there are many opportunities to reconcile, align systems, professionals, and patient family goals. We need to think about the rethinking expectations, professional roles, routines, and how to also prepare patient caregiver better while they are still in the hospital for that care transition. And when we are developing tools, we need to support both the obvious and invisible work at home, design more for gaps, not perfection, but resilient, there can be always surprises. The vendor may not be able to deliver the supply in the right time. So we need to design for surprises. And we need to leverage IT-based work system opportunities to support peer-to-peer support, community support, and learning opportunities while at home. Thank you.
Get ready with your questions. We'll get ready up here. Who's first? Thanks, Greg. It's up to you to get us going. Everybody else be thinking.
So, I was particularly struck, looking at Ayse's last couple of slides, and it really did get me to think, we tend to think about, we really want people to stay at home, they want to live a healthy existence, they want to be independent, but inevitably they do go into healthcare in some form or another now and again. It creates this growing complexity of treatment typically when that happens. Which you illustrated quite nicely. So I'm just curious, if you were to start to think about technology support with that aspect of care of older adults, how would you envision that taking place? Do you envision different ways that a doctor can give them, like just an app that supports their medications? Is it more providing something to the family? Is it direct support from some of the source? I mean, what would be the right sort of model for that, given, as you showed, the disparity of ways that people have to try to portray that information?
Sure. So I think this is, if I knew the solution for that, I would not be here. I would be running a big company now, right? So, but it's a great question, and I think it is multifactorial. We don't want, I always think of a few years ago I was doing a study in cardiac operating room and published a paper called Technologies in the Wild, where technologies don't talk to each other. There are additional paperwork that people create as workarounds, etc. I'm just hoping, Dr. Hager, the picture you showed this morning, we don't end up with these apps in the wild at home. So we need to be careful about throwing one more app into this work system. So that is number one. Number two, I think in addition to, so technologies should, and it is easy to say than doing it, technologies should be done so that they help the person, the patient and family, yet they need to be tailored. And this is going to be also pretty tricky because cardiac surgery is still cardiac surgery. It is relatively more standardized, but home, oh my God, there are all sorts of people who have all different preferences. Think about how they want to manage their care. So that will be critical in the success of future technology. Third is these responsibilities at these intersections. Roles and responsibilities. The clinician who is discharging this patient, oh, it's not my patient anymore. Oh, who will deal with this patient's questions now? There is some of this already. So these, looking at the overall system rather than looking at, patient is discharged and it's not my responsibility, he or she needs to go to PCP. There is a lot of that. So there are all these other factors that need to be really thought of for a work system to work. And the last thing I will say is situational awareness across these different work systems is really bad. a home care nurse dealing so much these days, figuring out what information was given to that patient before discharge at this age is unbelievable, but they spend a lot of non-value adding time and tasks in their day to that job. With that, I will stop.
Did you want to add in?
Yeah, I would say the first step in medication therapy management is reducing the number of medications. The more medications the older adult has, the more complex the regimens, the higher the non-adherence, and the higher the chances of drug-drug interactions. So again, the first step is to ensure that all the different clinicians who are prescribing are coordinating and or engaging a consulting pharmacist to do medication reconciliation, medication review on a regular basis that aim to reduce polypharmacy, essentially reduce the number of medications, and then it becomes much more palatable or much more manageable.
Kesh?
I think this is a great opportunity for AI type application. Dan has been working on this project on Avatar. He mentioned a little bit, but I know a little bit more about his project. And it's basically a voice-activated system like Alexa, where you look at prescription or someone who's a caregiver can look, and it goes through and converts it into language that you or I can understand. And it's a huge help. You know, it really doesn't matter. I think almost everyone in this room, unless you're a doctor, even doctors sometimes are confused with the prescription. And so it's not just the whole process is not designed to be simple. You know, it's extra effort is taken to make it difficult.
Yes.
I got a medication every 8 hours. I'm still confused what every 8 hours mean. I'm sure, you know.
So I guess maybe to kind of respond to that. So I mean, one of the interesting aspects here is you talked about the systems level. If you think about an engineered system, fundamentally what you'd like to do in engineered systems is reduce variability to the point that you achieve scale in an interestingly simple way. Yet, you know, what you're illustrating is that as you drive down to older adults, actually, as Sarah kind of pointed out at the beginning, older adults tend to increase in variety as they age. So I find there's an interesting tension here between
Yes.
trying to create systematicity around care and at the same time acknowledging variability. One thing that comes to mind that everybody has any thoughts on is when MOOCs started, they actually started to make interesting discoveries about learning because when you were teaching a class of 20 or 30 students, every student is uniquely different and they tend to get test answers wrong in their own unique way. But when you start to teach 10,000 or 30 or 40,000 students, you find out that even though there's a large variability, in fact there are natural groupings that start to emerge. There is an actual structure to what might seem at a small scale, something that for every case is uniquely different. I'm wondering, you know, maybe just in the interest of speculate, you know, as we start to put technology out there, do you think there is that opportunity to start to find unique commonalities across groups that maybe we don't see now simply because we're really looking in very small n?
Any thoughts?
Well, I think there's an interesting sort of line of research where they're doing personalized medications based on proteomic and genomic profiles of individuals. That's why some medications, people take certain medications that are prescribed to them, but they do not take in effect. So again, that's a small line of research, but the more sort of programs like the personalized medicine program out of the NIH sort of grows and starts collecting these samples and creating those genomic profiles, we may get to personalized medications at some point. Yes.
So so many of the big hospital systems are already trying to use their EPIC and other database to analyze the patterns in, you know, drug prescription and things like that. And there are tools today which can look for most obvious interaction between drugs and provide warning. So those things does exist, but in a very, very small way. But at least I know a couple of hundred hospitals are prescribed to this kind of software. But I think that this is, like I mentioned earlier, it's really a big data problem which can probably identify patients in a much better way if only we analyze what's happened in the last 10 years. And it can be done. And some very elementary work I have seen, but not in a big way.
Sarah?
Thank you for an excellent panel. During the lunch break, I got to talk with a participant whose spouse had had a transplant of an organ. And he made the excellent point that, this is for the caregiver panel before and for you all, that the hospital had really figured out how to involve the family because it was crucial, right? And organs are limited and there's a lot of energy around making sure that they work and that they're not rejected. And so, at least in his experience, there was excellent caregiver training and how to give IVs and manage the medications. And, sometimes we talk about learning from pediatrics in terms of involving families, but I wonder if we should really be trying to learn from transplant folks and if that's something that you all have thought about or if there's research around that.
So I don't know whether we talk with the same person, but there is a transplant patient that I talked also, not today, but he's actually on our patient family advisory board, and we got in-depth information about how he developed his medication schedule at home and how people in the hospital were so much paying so much attention. That was during that discharge process, because as you said, this is like very risky period. And they really, he explained us his methodology of how he tracks of how many hours before lunch, after lunch I take this medication, etc. So definitely there is a lot to learn. I haven't done this systematically, but I have anecdotally talked with some of these, and complex care pediatric patients are also another population.
Thank you. I have a question for the panel. I get this question a lot when I'm presenting about using technology to support older adults at home, and Ayse mentioned resiliency and being prepared for when things go wrong. So I'd like to hear from everybody about how do we build that into our systems, both the maintenance of the technology we're putting in the home, but what happens when it's not working, and maybe particularly in rural areas if you don't have a good signal. What are some things we can think about? And then another bit of that is also how to integrate across different systems. So how do we do some of that? Any thoughts?
I think this is it's a very topical question. I just saw a cartoon yesterday where someone was having a teleconference to talk about technology, and the other person says that my firewall does not allow me to connect network, please fax it to me.
That's good.
So, this is very true, right? There are people who have rotary heart, and the rotary heart, it pumps, so people go home and they carry a battery pack. So a woman had a problem with the chest pain, which 911 thought is a chest pain, and they came with an AED device. You cannot, it's a robot, it's a machine. And she had it for 8 years, so she knew enough to tell them not to do, but they were so confused because she was alive and they had no heartbeat, all the 911 people. So when you talk of technology, this is starting from battery failure, you can start thinking everything that can go wrong will go wrong. We know that already. And so I think this is where this monitoring and all these cloud-based systems really come into picture, right? Because there has to be monitored. Planes go down and we do not know where the plane is, the Malaysian Airlines, right? With all the technology, we don't know where it is even today, right? So this thing can go wrong at the very high tech. And imagine doing that with millions of people at home with all the sensors. But I think you rightly pointed out that once you start giving people at home, this is going to be a big problem. But I think monitoring is important. So that brings us to another problem that I have been talking to people about rural community and find out that, lots of people in rural community really do not have a smartphone. You just assume everyone has a smartphone, people do not. So when you talk about cloud and apps and things like that, hospitals sometimes will have to give a smartphone along with everything else just to make connectivity. So I think you bring a big point, but I do not know there's a one solution for that, but I think it's something we should think about.
And it really depends on the criticality of the application, right? Whether it's a safety, life-threatening situation, and then of course you need to build in redundancies. You need to build in those system heartbeats and checks, and if the system is going to run out of battery, or if it's a networking, you need to make sure that there is a redundant connectivity available, or alternative power source, and so on and so forth. So it really depends on the criticality of the application.
I think you need to always think of the basics. Human is still the most, human is still the smartest thing in that work system. That patient family system should have the critical thinking skills to be able to develop, go to plan B. Okay, if there is no technology working and I really need this, I need to at least call and try to get this ASAP. So, for example, I will give an example quickly. A real from a real home visit we had, a patient discharged with 3 different anticoagulants. So patient comes home totally confused and decides not to get any of the anticoagulants. So no technology can kind of, perhaps something can fix it, but the point is here that patient family work system didn't gain that critical thinking that they definitely need that anticoagulation.
I would say that probably that's interworking of the clinician system did not work. If they were coordinating, they would have one coagulant prescription.
Okay, wait, we have 2 more questions and then we'll wrap up. So
Thank you, panel, and my question is for Dr. Alwan, but I'd be delighted if anybody else wanted to weigh in. I'm a professor in public health, and so I was delighted to hear you speak to prevention, and I agree with you that many of the preventative behaviors are things that we know we should do, and yet, for many of myself, many of us, it's hard to just do it.
It is.
I've often felt that things like wearables and data provided back to people can be powerful health communication and motivation devices, and yet some subtlety is needed. So I'd be curious about your thoughts, both about what the state of the art is and what the opportunities for innovative research for communication strategies to motivate positive behaviors would be.
Exactly. I'm personally vowed to live successful aging. As I mentioned, I'm 53. I have predisposition to hypertension, and I managed through exercise and healthy diet to lose 30 pounds and cut my blood pressure medication by 75% over the last year. So I know it's hard, and I do exercise 5 times a day, but as you said, my Fitbit reminds me, I track my steps, but if we have also potentially a community, right? Again, a community that I can exercise with. That's why I enlisted all my family to do karate all together. So they encourage me, I encourage them, we drag each other. If nobody goes, I don't feel the same level of motivation. But again, that's where potentially you can have social connectedness applications. Sort of potentially, I'm going to for a run today. Is anybody interested among your friends and family and so on and so forth? So again, and also knowing what ticks, right? So I do not like running, for example. If somebody goes swimming, I'm right there, right? So again, but technology and especially the social connectedness and communication and the immediate notification capabilities are extremely powerful.
Great, thank you. Dan?
There's a tremendous amount of work that I can tell has been done here. Profiling the care cohort, let's call it for right now. And there's been successful programs around the country for years that had to do with known chronic conditions like diabetes at Dartmouth and different places. So there's a couple things here that maybe I can get y'all to expand on. There's the idea of the profiling of what the worker roles are with the providers and how those are today, and in this model that you've discovered in dealing with people at home, how have those roles changed, and how have you dealt with the group as you've done studies? How have you gotten them to change, and what were some of the issues that you faced over and over again about that change? And then to the organization, just not to make this a complex question, but then the next step along that continuum will be the health system or the organization that you're running the programs in, that you're running the studies in. How have they adapted, and do they start thinking about how they would cover this monetarily after a grant's given out, let's say?
We'll have to do a quick answer because we're past our time, but does anybody have a quick comment, and then maybe you can talk to Dan more after?
I can answer the last piece. The last piece, I think we're seeing a lot of interest from Medicare Advantage plans especially given the flexibility that CMS has given them in the last year or so. They're starting to cover telehealth. They're starting to cover services that are considered social supportive services, supporting the social determinants of health. So in terms the how the caregivers adapt, it's easy for them to adapt if they're getting the right sort of incentives. Without that incentives, it's really hard. That's the short answer.
Good, that was good. Do you have a short question?
Yes.
Go ahead.
About the prevention side, like that, I think they're designed to encourage like patients or people to do outside. Like, I'm from China, we have different culture and things. When I see things somewhere differently, like the community, we're outside your house. There's not much like a place where you can do activities. It's like a gym used in outside of your door. So that would be very convenient for people to do access while you're up their work from the parking garage to their home. So I don't know whether there are some design maybe eventually could help with this.
There are adult jungle gyms, and some of them are actually have technological advances, and there are games, and you have to touch certain areas and lights, and it tracks your performance. So I'm aware that some of the retirement communities, lifetime communities that we work with are exploring in sort of deploying some of those outdoor activity areas.
Great. Well, please join me in thanking our panel.